PPE, standard and isolation. Indications: prevents the spread of infectious diseases between patients and the provider. Considerations: it's essential to ensure proper donning and doffing of PPE, as well as using the correct PPE for each isolation. How it works: PPE protects the provider from the pathogen that the patient is carrying. Outcomes: reduces the chances of spreading the disease. Comparison: airborne equals pathogens in the air, droplet equals pathogens that are carried in respiratory droplets, and contact equals pathogens that are spread by contact with an infected patient. Techniques: contact equals gloves and gown, droplet equals eye protection and mask, airborne equals N95 and a negative pressure room. Equipment: gloves, mask, gown, face shield, N95, and goggles. Oxygen cylinders. Indications: oxygen cylinders are used for patients who have hypoxemia, COPD, heart failure, and pneumonia. Considerations: keep the oxygen tanks away from open flames. Also, secure the tanks to prevent them from falling and exploding. How it works: pressurized oxygen is supplied to the patient via the regulator and the flow meter. Measurements: cylinder pressure is measured in psi. The flow meter is measured in liters per minute. Equipment: there's two types. There's E cylinders that are used for patient transport, and H cylinders that are backups if the pipe system has failed. The settings: E cylinder is 0.28 and the H cylinder is 3.4. The formula for the duration of flow is psi times the factor divided by the flow in liters per minute. Peak flow meter. Indications: monitors airway obstruction in patients with COPD and asthma. Considerations: patient must be able to create a seal with their lips and be able to complete the procedure as instructed. How it works: it measures the maximum expiratory flow after a full inspiration. Measurement: peak expiratory flow and its units are in liters per minute. Technique: after a full inspiration, the patient must perform a fast and forceful exhale. Frequency: the patient should use the peak flow meter at least twice a day. Ranges: normal ranges for adults is 400 to 700 liters per minute. For children, it should be 150 to 450 liters per minute. ABG sampling. Indications: assesses the oxygen, carbon dioxide, and acid-base balances in critical patients. Considerations: perform the Allen's test, expel air bubbles, prevent clotting in the syringe by using a heparinized needle, and ensure immediate handling for analysts. How it works: blood is collected from the radial artery using a heparinized needle. Once it's collected, it's sent to the lab for analysis. The measurement is pH, PaCO2, PaO2, and bicarbonate. The full name is arterial blood gas. The technique is: begin by performing the Allen's test, angle the heparinized needle at 45 degrees, and puncture the radial artery. Allow the patient's blood to fill the syringe to at least 1 milliliter. Normal and abnormal ranges: pH is 7.35 to 7.45, PaCO2 is 35 to 45 millimeters of mercury, and bicarbonate is 22 to 26, and PaO2 is 80 to 100 millimeters of mercury. Abnormal ranges can be interpreted as an acidosis or an alkalosis. As for PaO2, an abnormal range can be read as mild, moderate, or even severe hypoxemia. Pulse oximeter. Indications: the pulse oximeter measures the SpO2 of a patient who has respiratory/cardiac issues or is suspected of hypoxia. Contradictions: poor perfusion, motion, nail polish, and cold fingers can give a false reading. How it works: the pulse oximeter uses light absorption to measure SpO2. Measurement: it measures SpO2 and heart rate. The normal range is 95 to 100%. Abnormal range: anything below 90% is considered hypoxemia. Comparison: different probes include the finger, forehead, and ear. Nasal cannula. Indications: nasal cannulas are used on patients who have acute hypoxemia, respiratory failure, pneumonia, and heart disease. Contradictions: deviated septums and nasal obstructions can reduce the effectiveness of a nasal cannula. How it works: it delivers supplemental oxygen through the nostrils. Measurements: flow rate and FiO2. Flow range is 1 to 6 liters per minute. Percentage range is 24 to 44% for FiO2. Hazards: the nasal cannula can cause dry and irritated nasal passages. Also, inaccurate oxygen delivery can cause the patient to breathe too much or too little. Air entrainment masks. Indication: air entrainment masks are used to deliver oxygen at a precise FiO2 by mixing it with room air and giving it to patients with unstable breathing patterns. Considerations. The FiO2 and flow rate must be at the correct settings, also making sure the air entrainment port isn't blocked or covered. How it works. It works by mixing oxygen with room air through the device's ports. The Venturi principle is used to deliver the correct FiO2. Measurements. FiO2 is 24 to 40%. Formula. Total flow equals air parts plus oxygen parts times the flow. The air plus oxygen represents the O2 ratio. Flow range. The flow range is 4 to 15 liters per minute. Who benefits? The air entrainment masks benefit patients with COPD, chronic lung disease, or patients who are hypoxemic. Partial and non-rebreather masks. Indications. The partial rebreather and non-rebreather masks are essential for providing oxygen to the patients who require a high FiO2. Contradictions. For the partial rebreather, avoid using on patients who have poor ventilation or CO2 retention. For the non-rebreather, avoid using on patients with respiratory failure. How it works. A partial rebreather delivers oxygen, then the patient breathes in their own exhaled air through the reservoir bag. The non-rebreather works by breathing only oxygen. Outcome. The partial rebreather and non-rebreather masks will help improve oxygenation and SpO2 levels. Comparison. The partial rebreather uses the reservoir bag to allow the patient inhale the exhaled air. The non-rebreather has a one-way valve that prevents the patient from rebreathing the exhaled air. Flow range. The flow range is for a partial rebreather and a non-rebreather mask is 10 to 15 liters per minute. A non-rebreather can go higher if needed. Percentage range. A partial rebreather mask has a percentage range of 40 to 70%. A non-rebreather has a percentage range of 60 to 80%. Aerosol and simple mask. Indications. Aerosol masks are used for patients with cystic fibrosis, COPD, and asthma. Simple masks are used for patients who can breathe on their own but need a higher level of oxygen concentration. Contradictions. For aerosol masks, there are risks of aspiration, patient intolerance towards the mask, and unstable breathing or apnea. Simple masks can be ineffective for chronic CO2 retainers because they can develop hypoventilation. How it works. Aerosol masks deliver humidified oxygen or medication to moisten and loosen airways. Simple masks supply concentrated oxygen and room air to the patient to inhale. Outcome. The outcome of aerosol masks can mobilize secretions and improve airway hydration. The simple mask reduces hypoxemia and improves oxygenation. Comparison. Simple masks deliver only a moderate oxygen concentration, while aerosol masks deliver humidified oxygen and medication to the lungs and nasal passages. Techniques. For an aerosol mask, make sure the reservoir is upright and ensure the mist is visible. For the simple masks, ensure the flow rate is at least 5 liters per minute. Who benefits? Aerosol masks are for patients with asthma, COPD. Simple masks are for patients with mild or moderate hypoxemia. High-flow nasal cannula. Indications. A high-flow nasal cannula is for a patient with hypoxemia, increased work of breathing, and in need of a precise FiO2. Considerations. Check the flow settings, make sure everything is connected, and ensure the humidifier is at a correct temperature. How it works. A high-flow nasal cannula delivers heated and humidified oxygen at a high flow rate to improve oxygenation. The high-flow nasal cannula is connected to a heated humidifier to prevent dryness in the nasal passages. Outcome. The high-flow nasal cannula improves oxygenation in patients, allowing them to breathe more easily and reduce their work of breathing. This will ensure the patient's comfort and care. Hazard. A high-flow nasal cannula can cause irritated skin, dryness of the nasal passages, and even discomfort if the heat is set too high. Settings. The FiO2 is 21 to 100%. The flow rate is 20 to 60 liters per minute. Who benefits? Patients suffering from hypoxemia, respiratory failure, and in need of a high FiO2 to decrease their work of breathing. MDI. Indications. An MDI is for those who are experiencing shortness of breath, wheezing, or bronchospasms. Contradictions. Patient who can't coordinate the MDI or aren't able to hold their breath. How it works. The MDI releases medicine into the patient's lungs by using pressurized air. Measurements. An MDI is measured by the number of doses per canister. The full name is metered dose inhaler. The technique is to exhale completely, seal the lips around the inhaler, press down, and inhale fast and deep. Then hold for at least 10 seconds before exhaling again. Who benefits? Patients with asthma and COPD will benefit. DPI. Indications for patients experiencing shortness of breath, bronchospasm, or inflammation. Considerations: make sure the patient doesn't exhale into the device, keep the device dry, and be sure the patient rinses their mouth afterwards. How it works. Similar to the MDI, the patient inhales from the DPI and the powder medication will disperse into the lungs. Measurements. A DPI is measured by the doses per canister. Full name: dry powder inhaler. Technique: sit in a semi-Fowler's position, then create a seal with your lips and teeth around the mouthpiece. Inhale fast and deep, then hold your breath for at least 10 seconds. Who benefits? Patients with asthma and COPD will benefit from a DPI. Small volume nebulizer. Indications: patients experiencing wheezing, shortness of breath, and showing signs of respiratory distress. Considerations: the patients may experience an allergic reaction to the medication, or they may be unable to hold the device. How it works. The small volume nebulizer takes the liquid medication and creates an aerosol to distribute to the patient through a mouthpiece. Outcome: the SVN can reduce wheezing and bronchospasm and improve airway clearance. Comparison: there are two ways to deliver the medication: by continually breathing the mist or taking an inhale of the medicine every few breaths. Technique: have the patient sit in semi-Fowler's position and have them breathe as they usually do, then every so often ask them to take a deep breath of the mist to ensure they are receiving the medication. Who benefits? People who benefit from SVN usually have asthma, COPD, or an airway obstruction. Incentive spirometer. Indications for patients who are at risk of atelectasis after abdominal or thoracic surgery. Contradictions: if a patient is experiencing pain after abdominal or thoracic surgery, they shouldn't use it, as well as if the patient can't take a full breath. How it works. The incentive spirometer encourages the patient to take slow, deep breaths to help the lungs expand and prevent fluid buildup. Measurements. The incentive spirometer measures the capacity of air your lungs can hold in milliliters. Instructions. Instruct the patient to sit in a semi-Fowler's position, then have them seal their lips and teeth around the mouthpiece and take a slow inhale. Technique: have the patient inhale slowly and deeply to get the ball to rise. Then, if they can, have them hold it for 3 seconds. Frequency: the patient should use the incentive spirometer 10 times per hour. Intermittent positive pressure breathing. Indications: patients with shallow breathing, low tidal volumes, and muscle weakness can use an IPPB to help them with symptoms. Contradictions: a patient with untreated pneumothorax, hemoptysis, or a recent lung surgery may face more complications when using an IPPB. How it works. An IPPB machine works by delivering air at a positive pressure for a patient to inhale. The machine will push the air into the patient's lungs when they inhale, and it can also deliver medicine. Measurements. The IPPB measures peak inspiratory pressure and forced inspiratory vital capacity. Who benefits? A patient with atelectasis, decreased lung expansion, or buildup of secretions may benefit from an IPPB. Settings. 3 controls. Pressure, flow, and sensitivity. Settings. Control effects. Pressure controls the depth of the breath. Flow controls the delivery of gas. And sensitivity triggers the patient to breathe. Chest physiotherapy. HFWCO, percussion, and PEP. Indications for patients with built-up secretions who need help mobilizing them. Contradictions: people with a lung injury, recent thoracic surgery, or hemoptysis should not use these devices. How it works. Mechanical vibrations are used to mobilize secretions to help clear them from the lungs and the airway. Outcome: the CPTs will loosen up the secretions, allowing them to be easily expelled from the body when the patient coughs. Then the airway can become clear and it's easier to breathe. Equipment. There are 3 types: high-frequency chest wall auscultation, vest, percussion, cupping of the hands or mechanical percussor, and PEP, which is the flutter valve and an acapella. Technique: postural drainage, lying in different positions and allowing gravity to move the secretions. Who benefits? Patients with pneumonia, cystic fibrosis, and bronchiectasis. Suctioning, oral and nasotracheal. Indications: an invasive procedure to help remove secretions from either the nose or the mouth. Considerations: make sure that the suctioning tubes are properly sterilized and lubricated. How it works. The suction tube is inserted either in the nose or mouth of the patient, then the tube extracts the mucus and saliva to be sent to the lab for analysis. Outcome: nasal and oral suctioning allows for clear airways, improved breath sounds, and overall better oxygen saturation. Comparison: nasal suctioning are for when the mouth can't be accessed, like like intubation, and the secretions are deeper. Oral suctioning is for the visible secretions that are easier to remove. Technique: sterilize the suctioning tube, make sure it's the right size, then lubricate it before inserting it into the patient's nose/mouth. Then begin suctioning as you're pulling the tube out. Hazards: nasal/oral suctioning can cause a gag reflex and vomiting, an infection if not sterilized, and airway edema from repeated suctioning and incorrect tube size. OPA and MPA. Indications: OPAs are for patients whose tongue is completely obstructing their airway. MPAs are for patients who have a partial obstruction. Considerations: make sure to select the correct sizes for both. For OPA, measure from the jaw to the corner of the mouth. For MPA, measure from the ear to the tip of the nose. How it works: the OPA prevents the tongue from obstructing the airway. The MPA provides a clear pathway for airflow through the nose, bypassing any upper airway obstructions. Outcome: the OPA and MPA provide an open airway and improved oxygenation. This allows for effective suctioning and ventilation. Comparison: OPAs are for patients who are unconscious with no gag reflex. MPAs are for patients with a gag reflex and are in need of frequent nasal suctioning. Technique: for the mouth, insert the OPA by pinning the tongue down, then rotate it 180 degrees as it passes the tongue. For the nose, insert the MPA by lubricating the tube first, then insert down against the floor of the nose towards the septum. Hazards: some hazards may include gagging, vomiting, bleeding, and infection if not sterilized. Endotracheal tube. The indications for an endotracheal tube are for patients experiencing inadequate ventilation and airway obstruction. Contradictions: ensure that the patient always has a supply of oxygen, make sure that the tube is sterile, and be sure that the patient's tube is always secure in place. How it works: the endotracheal tube is inserted into the trachea, maintaining an open airway for the patient to receive air from a ventilator. Outcome: the endotracheal tube allows the patient to have a secure airway, improved oxygenation, and provides them mechanical ventilation. Technique: use the laryngoscope to guide the endotracheal tube down into the trachea. Then inflate the cuff and pull out the stylet. Lastly, check with a CO2 detector. Hazards: complications that can arise from an endotracheal tube can be a cuff leak, right mainstem insertion, and trauma from improper insertion. Who benefits? Patients with pneumonia, ARDS, respiratory failure, and airway obstruction can benefit from an endotracheal tube. ECG. Indications: ECGs are used to monitor the electrical activity of the heart. Considerations: ensure the patient is prepped by removing dead skin, hair, and oils from the chest to get an accurate read. How it works: an ECG reads the heart's electrical activity through the electrodes on the chest and limbs. Measurement: the ECG measures the heart rate and rhythm. Full name is electrocardiogram. Technique: place the leads V1 through V6 in right leg, right arm, and left leg on the chest and forelimbs. Who benefits? Patients experiencing chest pain, shortness of breath, and abnormal heart rhythms benefit from an ECG.